Okay, I think we should start. Good afternoon, everyone. My name is Martin Kirkpatrick. I'm going to introduce this session. So the aim of this lunchtime grand round is to give you a flavour of some, but by no means all, I suspect, of the volunteering work that goes on in NHS Tayside and the medical school. Particularly in low and middle income countries around the world. And we've got a smorgasbord of very different work by a group of very different individuals, but all of whom are excited and enthusiastic about the work that they're doing. And the context of this is wide, but there's been a recent publication which sets out some of the scene around this. And this was a document published by the Royal College of Physicians and Surgeons in Glasgow just last month. And this work has been strongly supported by the Chief Medical Officer of Scotland, and indeed she chairs a group which is looking at taking this work further forward. And there's a similar document that has been up to the NHS Tayside out to NHS Tayside Health Board very recently. So many of us are very pleased to see these documents, since aside from the benefit to those individuals in the country where that intervention is taking place, there are huge benefits both not only to the individual undertaking that work, but also to NHS Scotland. And so our aim is that we will inspire you perhaps to find out more and even to contribute to this work. And in amongst all your hundreds of emails, last week you may have seen one which came from the medical director, and it included a request to fill in this online survey. So please do complete this if you've not already done so. And I hope that this will be a way of starting to bring the issues of global citizenship get through to NHS Tayside and to the medical school. So we're going to kick off now. We've got we had 7 speakers in the election debate last night. We've got 9 speakers today, but the standard of debate will be much higher. We won't be weak and we won't be wobbly, and there'll be no shouting. So I'm going to kick off. We're going to try. It's very unlikely there'll be time for questions afterwards, but we're all very happy to hang around afterwards if you want to come and talk to us individually. So I'm going to kick off by starting to talk about international paediatric epilepsy training, all these things called PET courses. And this is run through a small professionals charity called the British Paediatric Neurology Association, and essentially is a group of really enthusiastic individuals who've wanted to take this issue forward. And this all started in the UK about 10 years ago on the back of concern about standards of care, and also around a way of trying to implement published clinical guidance, because of course all these guidelines so often sit on bookshelves. So that we sat down and developed a series of standardised educational materials which could be delivered by a trained faculty in the context of a small workshop-based teaching with no more than 8 participants in each group. And to our astonishment, this has really taken off. And so that in the space of 10 years, we have put 7,500 clinicians through a PET course all around the country. And then what started to happen in the latter half of this was that people who had been trainees, who had gone back to their own country, people who had come from overseas, started to say, can you come and run a course in our country? And again, just to put this into context, in the developing world, this is the most common serious neurological disorder in children, a prevalence rate of 14 per thousand. And this World Health Organization global campaign against epilepsy, their strapline that 75% of people across the world who have epilepsy are untreated, and yet 3/4 of those are easily treatable. And of course, the consequences of untreated epilepsy are legion, particularly in children. So things like falls and fractures and drowning. And this child from Canty Children's Hospital who fell into a fire and suffered burns. And indeed, in that burns unit, 50% of the children in that burns unit were there who had had a seizure or a collapse of some form and fallen into a fire. And of course, the whole issue of educational societal exclusion is a real issue, not only in this country, but of course across the world. And the model that we have put together is bringing out an experienced faculty to that particular country with a local faculty who we train up on the first day, go through a train the trainers on the second day. This one-day course would then be delivered by that new faculty with mentoring by the experienced faculty, and then they would take that out to their own cities. And so that in the context of a period just under 2.5 years, with 2 centre launches in India, this is now rolled out to 17 cities in India, and we're working in Nepal and Myanmar as well. It's gone further than that. We've run courses in South Africa, in Kenya, in Sudan, in the Gulf states. A group of people just come back from New Zealand, and we're about to launch courses next year and 2019 in South America. And so that already the number of participants being trained internationally exceeds that of the case in the UK. So what have we achieved? Well, we've got a volunteer army. Using a combination of study leave and annual leave, and we've achieved a series of short course education programs delivered by a trained faculty with consistent standards of delivery, and we've worked hard at trying to work out at the quality assurance framework around that. And absolutely key is sustainability. There's actually very little point in just running one course. You have to make this sustainable. So that finally, can we, at the end of the day, raise standards of care for epilepsy in children, whether it's in Nottingham or whether it's in Canty Children's Hospital in Nepal? And the picture of this little girl who's called Sharmila, who again fell into a fire following a seizure. Are we able to try and prevent these life-changing injuries, for example, by getting the right diagnosis and offering these children appropriate treatment? Thank you very much.
Okay, it's not me. No, I think we've just gone back onto that. Right, okay, thanks. Okay, this is something completely different. Everything is completely different. We've actually been doing a pathology link with Africa through the Scottish Pathology Network, which is a managed diagnostic network across the country, but actually coordinated here from Dundee for 10 years now. I've only got 2 slides, so I might actually save some time in this. So where does pathology fit in? People are always dashing out to Africa doing dashing things. We obviously lying in the background. But pathology is key in 2 ways. It's key for education. One of the ways in which Africa has to evolve is by training its own doctors. Sub-Saharan Africa has vanishing numbers of qualified people in most areas, and that includes pathology. All pathology in Sub-Saharan Africa tends to be based in medical schools, so typically a country will have one department of pathology which is based in the National Medical School, and that's been our experience in the countries in Malawi, Zambia and Botswana where we've had contact. It's core to undergraduate teaching and, importantly, postgraduate training in a number of specialties. And people actually do train in these specialties often without ever, in the past they've trained without ever meeting a pathologist, which has social advantages but not very good professionally. Pathology is also central diagnostically to dealing with the evolving problem of cancer, and cancer is becoming a huge issue in developing countries. 60% of the world's new annual cases occur in Africa, Asia, Central South America, which is relatively much higher than their percentage of the world population, and they account for 70% of the world's cancer deaths. And there's a big initiative World Health Organization and otherwise run to try to get cancer treatment going. And certainly in Malawi, where many of us have worked, until relatively recently, there was no chemotherapy apart from for Burkitt's lymphoma and no radiotherapy, so no treatment for cancer locally apart from surgery. And the other point I would make about the clinical utility of pathology in developing countries is certainly in the poorer countries like Malawi in southern Africa, the vast majority of patients registered and treated for cancer never have a confirmed diagnosis. And that was brought home to me on my first ever day in 2007 when I went to the pathology department in Blantyre, Malawi. Looked at a slide. While I was there, I said I would report some pathology which had been sitting there for months. It was a biopsy of a woman's pelvis frozen by tumour, and the biopsy was to confirm. And I looked at it, and it wasn't. It was tuberculosis. So rather than cervical cancer, she had TB. I went to a lot of trouble trying to find the hospital where this had come from, phoned them up, and she was dead. But she died basically of communicable illness which had been mislabelled as cancer and treated that way. So this is the kind of thing that happens. So what we've done, very little detail, but it's been ongoing for, as I say, for 10 years. We were involved with Malawi initially from 2007 to 2012. Still have contacts in Malawi, but no active participation. I met a guy from Harvard pathology who was doing research out there, and he became involved in the project we had and then took on a big American commitment with it, and they've now basically taken that over, which has worked very well. So we're involved in teaching at undergraduate level, in trying to support the diagnostic service and in training of the laboratory staff, and we had one person went out there for a year, a biomedical scientist from Aberdeen, in revamping their laboratory. And they've now gone from, this man on the right here is Steve Kamiza. When I went out there, he was the only pathologist in Malawi, which is a population then of 12 million, and he was basically firefighting and not really able to provide anything like a service. The numbers they were seeing were very, very small. We then became involved in Zambia and Botswana, basically through integration with other efforts going on through the Royal College of Pathologists and the South African College of Pathology in developing MED. Master of Medicine is a kind of postgraduate standard program that people have across sub-Saharan Africa in different specialties. So we've developed curricula for MED programs, and some of us have been out teaching in Zambia and more laterally in Botswana using the same program and extending it. And one final thing I think is important is that what you do when you do these things is you make contact with somebody locally. So you have somebody like Steve Kamiza who is working by himself, and I think having an email contact with somebody somewhere in the world that you can run a quick question by or even moan about things actually is very helpful when you're the only professional in your specialty in a country. He wasn't alone in that. There was other people who are not represented here today, including psychiatry, for example. There was one psychiatrist for the country as well. So this support and mentoring is important. It can also lead on to important efforts that we can take forward, and certainly one of my ambitions in the next few years as I come up to finishing my career here is possibly spending a couple of years out there, having made the contacts, go and work in one of the departments, medical schools there on a full-time basis. So it's just a very basic outline and just to raise the flag. I'm happy to deal with questions later. Thank you.
So we're also talking a little bit about Malawi. We have had links between the medical school and the College of Medicine in Malawi for about 10 years now. The College of Medicine is based in Blantyre, right in the south of the country. And it's actually the only government medical school in Malawi. They graduate about 100 medical graduates a year, and their graduates are actually highly regarded throughout sub-Saharan Africa. We've had a number of links over the years. Our own students have done, our own students have done electives and intercalated degree projects there. We're also supporting a number of students through an organisation called Medic to Medic, who otherwise wouldn't be able to afford to continue their studies. And actually, for a number of years, we actually had exchanges where students came from Malawi and spent about 6 weeks doing electives in Dundee, and these were two of the earliest ones, and Judith is now actually a consultant surgeon. The money ran out for that, but one of my colleagues, Katie Daniels, is actually exploring setting up south-south electives, sort of inter-regional exchanges between medical schools in the region. Building on our sort of long-standing relationship, we were actually asked to help run a faculty development workshop in February of this year to help upskill the core faculty in medical education, and involving Linda, who's going to say a minute, from the Centre for Medical Education. And we were actually invited by Emma Thompson, who is in the bottom right-hand photograph, who is a consultant paediatric surgeon. But she's also chair of the College of Medicine Education and Training Organisation, and is very keen to develop the medical education capacity. And she's actually studying for a certificate of medical education with CME here in Dundee by distance learning. But rather slightly differently from just a sort of standard teach the teachers workshop, we actually used a particular approach called appreciative inquiry. And I'm going to ask Linda to say a little bit about that.
Yeah, so I think the first thing I want to do is to say I want to ask you two questions, okay? They're rhetorical, they're for you to just think about them. And that's the first one. Why aren't you doing more? Oh, it's doing its jumping thing. Let's go back to there. Why aren't you doing more to promote global health? What happens when you ask yourself that question? And then an appreciative inquiry approach. So my background isn't, I'm not a medical doctor, but my background has made a lot of use of something called appreciative inquiry, including in the London Deanery. And an appreciative inquiry question would not look like this. It would look something like this. In what ways are you and your colleagues contributing to the enhancement of global health? So it's saying to you, so what are you doing that's working? How can you do more of it? How can we do more of it? How can we build on what works rather than starting from that deficit point? So the old model of Dundee University or any university going into a country as poor as Malawi and saying, okay, we've come to fix you, we've come to help you, we've come to sort you out. We're a drop in the ocean. But if we can find out what they're doing well and help them do more of it, it's more likely that it is sustainable. So just to kind of give you a feel of it in 2 minutes, that's all I can do. But that's the kind of difference between the standard, more deficit approach, what's wrong, let's fix it, and an appreciative inquiry approach. So we went into Malawi. We knew we had a 2-day workshop at the end of the week, deliberately at the end of the week. We hadn't set it up. Neil and I sat in 2 rooms, next to the pool, albeit said it was next to the pool, but we sat there up all night designing the workshop based on the appreciative inquiry meetings we had with many different groups, so that by the time we built the course, it was on what they knew they needed, what they knew was working, and how to do it. So essentially, appreciative inquiry, and I'll leave you with this, it's as simple as that. It's saying, okay, so what's working? Then it's saying, okay, let's discover what it is that's making it work. Now let's look at what your dreams are. How do you want it to be? So how can we design more of what's working into how you do it? And then how do you want to sustain that? So the point I'm going to leave you with is that if you don't currently know about the Global Challenge Research Fund, there's some big calls for research funding on the way. If you want to know more about it, give me a call or email me. But we're hoping to make use of that to do a lot more of this, and we'd be looking for far more collaboration, so it's not, we can't do it on our own. So thanks.
Can you see all right? Indonesia, some statistics. Indonesia is the world's fourth most populous nation. It's the world's largest Muslim majority nation. It's the world's largest archipelago, 17,000 islands, of which 1,000 are inhabited. I was born there. When I came back to this country in the 1970s, no one had even heard of it. Some more statistics. One more statistic about Indonesia. It's got the highest GDP in Southeast Asia, the same as Saudi Arabia and Oman put together. That's not GDP per capita, but it should be a wealthy nation, and yet 50% of the population live on less than $2 a day, which is the international definition of extreme poverty. Don't think we need it quite that dark. Okay, we do, apparently. Sorry. Vision 2020 is a WHO and multinational, multi-agency, international, charitable commitment from all these organizations to eliminate avoidable blindness by the year 2020. That's 40 million people with avoidable or treatable blindness, of which 20 million, half of them, are due to cataract. Indonesia has the highest prevalence of blindness, being over 1% in Southeast Asia. What's wrong with this map? Look at the red. It stands out that the only country apart from Cambodia and Laos to the north there is Indonesia, elsewhere in the world, with a prevalence above 1,000. But in fact, if you look at the WHO data from 2000, it would suggest that if you put all the countries together, Sri Lanka, Thailand, Burma, Nepal, North Korea, Bangladesh, they've still kind of got less because it's a double whammy with Indonesia. You've got the high percentage multiplied by the largest population in the Southeast Asia region. However, their own recent surveys of blindness put the figure closer to 2.6%, which means it's way above that. So bang for buck, Indonesia is the place to be investing energy in trying to combat blindness. What about India? Well, India is bigger and poorer. In fact, it's 5 times the population size, and GDP per capita is much lower in India. But look, it's 5 times the size, but 12 times as many ophthalmologists. In Indonesia, there is a verbal commitment from the government, motherhood and apple pie, by all means, cure all blindness if you can. Whereas in India, there's hard currency committed by the government. The cataract surgery rate, that's the number of cataract operations per million, key statistic, 4,000 in India. To put that in context, America is 6,500. We're probably quite close to 4,000 as well. Indonesia is 500. Nigeria, sub-Saharan Africa, is 333. So it's at the level of sub-Saharan Africa. I said we're involved in Indonesia, more specifically this city of Makassar, population 2 million, the capital of one of the islands to the east of the country. But look at this for strategy, a 2 million population city with a population of that whole island of 17 million and a global reach in terms of medical education of getting on for 40 million, and tertiary referrals into that area as well. When we began to get involved, we've been involved since 2009, the situation in the city in which we work was they were doing just over 1,000 cataracts for a population of 2 million. Dundee's 1/5 of that population, we do 4,000 a year, and their prevalence of blindness and severe visual disability be way higher than Tayside's. So there's clearly work to be done there. Think of the culture. If you're going to get involved in a link overseas, it's not so much transfer of medical, biomedical information, perhaps pathology accepted, but you are definitely dealing with a culture. Think not of the race and the different clothes, but how did you get to the starting point in that race? And it's a commonplace to say culture affects everything, but it does. The definition of culture is just the way we do things around here. So it's religious culture, social culture, referral culture, medical culture, payment culture, all of that. And all I would say about culture, it's the Groucho Marx question that before you criticize anyone else, you should walk a mile in his shoes. And then when you criticize him, you're a mile away and you've got his shoes. But if you shine the spotlight on another person's culture, you'll find that the same stark, bright light shines on your own culture, and you may find things you're not so impressed with in your own practice. That is healthy, and it's good for us. Thanks very much.
Hi, thank you.
little bit about giving, but also getting. What do I get? What can we get? I've indulged in a bit of healthcare tourism for a number of years, both plying my trade with my interest in children's and airway anaesthesia for Operation Smile, Facing Africa, and also teaching and education of anaesthesia deliverers. Operation Smile, simple to fix and amazing that 4 to 5 billion people globally don't get access to this simple surgery. Look at that statistic. We gobble up rich people more than 90% of the surgical resources. Fantastic that the WHO is now focusing on this area. Sorry, these slides are moving themselves. And the deaths from lack of access to safe anaesthesia and surgery, or poor safe anaesthesia of surgery, outweighs those of TB, HIV and malaria worldwide. Some of the other work with Facing Africa, a hidden disease of socioeconomic deprivation. Acute noma, 90% of children die. They're hidden away in sub-Saharan Africa. It scars and heals, and if they're lucky enough to survive, you get that, and you get horrible deformities. And the surgical team goes out and performs quite significant surgery, free flap, microvascular free flap, apologies for the graphic pictures. This poor chap, with multiple operations, follow-up and repeated teamwork. You don't win a beauty contest, but hopefully it restores some function and some ability to live a life. Here's a team. In the NHS, I don't get to sit in a room with committee anaesthesia, about 3 or 4 people. Here's a trainee fellow, and applying standards of care around WHO standards of surgical safety, and teaching and training as much as we can for locals, and also applying that trade and in advanced airway techniques. Lots of things to learn and bring back here. So what? I've thought a lot about this. What's the point? We're only benefiting a few people, and that's absolutely true. So what about education? SAFE, from the AAGBI, my professional body, along with the World Federation Society of Anaesthetists, delivers training called Safe Anaesthesia from Education. Look at this statistic moving across there. We've got better and safer at delivering anaesthesia and surgery. Look at those outliers encircled by the red mark. That's how it's actually getting worse in low-income countries, albeit in small studies. Completely different set of circumstances in which they work. So fitting in a bit with Martin's thing, this is about refresher courses and a similar model, empowering local clinicians and upskilling them to deliver this teaching. There's no point us flying out, and I'm involved in the pediatric anaesthesia. No boring lectures with the lights down. It's all hands-on, having a bit of fun and interaction, and so humbling to hear about the circumstances in which these people work compared with the luxury I inhabit every single day. Let's not knock the NHS. Just one slide, and there's many, many of this showing the impact. Sorry, that hasn't come out, but that grey marks that go up the way, that's about skills. Knowledge dips after the pre-course to 12 months. But it's interesting, if you empower people and they apply their trade, in this case in obstetric anaesthesia, the skill level actually increases it as they use those skills. So it's important to measure the impact of what we do. So coming back to the getting part, there's a document from Nigel Crisp in the NHS and now the Scottish Global Health Collaborative Catriona will talk about. These are type of benefits, enacting change, teamwork. How fortunate we are to have the NHS, revitalising people, developing new interests, determination to change things, greater confidence and motivation. And I'll leave you with this final slide and a bunch of words on the side there. And I could probably think of a few more things that from a personal and a purely selfish point of view have been benefits that I've gained. And I'd urge and encourage all of you, particularly the young people in the audience, you're going to have an awfully long career. Think of ways that you can maintain the impetus of your career. This isn't for everybody. It might be cycling up a hill or up a mountain or whatever it is, but find ways to stimulate yourself. And one way you can do it is by engaging and helping the 4 or 5 billion who don't have what we have. Thank you.
Thanks. So I'm the founder of this partnership with our colleagues in Malawi, and I'm going to talk mainly about what we've done since 2005 with colleagues in Malawi to deliver a postgraduate focused small group teaching like you've heard Grant and Martin speak about. mainly on obstetric and paediatric anaesthesia and trauma management, to assist our colleagues in Malawi to try to improve maternal and neonatal mortality and in their efforts to pursuit of Millennium Development Goals 4 and 5. So before I focus on the Malawi work, I do want to pay enormous tribute to the work that was done. So we started in 2005, and in 2015, the three Kates there, Katie Orr, Kate Zealy and Kate Miller, and you didn't have to be Kate to be on the team, but the three Kates went off to Jamaica and took the product that we had developed, adapted it for Jamaica, and that's rolling out very well there by the team. So 2005 was Make Poverty History Week, and it was the signing of the Scotland-Malawi Partnership, and it was the year that we started some negotiations with our colleagues in Malawi to ask what can we do to help. And the answer came back that they would like some refresher courses, particularly in obstetric and paediatric anaesthesia and management and management of trauma. So four of us, you can see here Pamela Johnson, who's my colleague from Ninewas, and myself and two other colleagues from Scotland, went off, and we delivered an adaptation of the Advanced Life Support Group courses on advanced paediatric life support and managing obstetric emergencies and trauma to these 16 anaesthetic clinical officers in Malawi. And this gentleman here is the head of the School of Anaesthesia, and he's the project lead in Malawi. So while we were there, it became clear that others have blazed this trail and have popped in and delivered courses and left the Malawians with some additional education, but only for those who have attended the course. So we set about trying to work out how we could build some sustainability into the system, and that we had a great model from the Advanced Life Support Group on how we train some trainers, supervise and mentor those trainers, initially very, very closely, but then with more and more distant support, so that we hopefully leave them self-sufficient to provide ongoing education for each other. So we went back the next year. Somehow our two local instructors in the education faculty managed to miss this photograph, but Susan and Barry were both on the education faculty, so we trained the trainers to these 5 Malawians. And in order to do that, we had to run several courses together. At that time, there were three-day courses. So we were running 12 small group sessions contemporaneously. So we had a large faculty from Scotland so that we could deliver the courses, and that the new Malawi faculty could be mentored for every session that they were training. On that course, we taught our updated 48 anaesthetic clinical officers. And over the period between 2006 and 2012, we delivered 43 courses on the subjects noted below. And that left us with a project lead and 5 Malawian instructors who were capable of delivering the teaching to their own colleagues. We sent a lot of equipment, some of which was reconditioned theatre monitors by our colleague Graham Matthews in medical physics here, and with support from the Ministry of Health in Malawi and all of these other components. We helped establish 11 high dependency units within Malawi, and we have data from 3 of those which show the impact of the high dependency units just on maternal death, so a decrease of 50% in each of the centres on maternal death, as well as additional other changes that occurred for surgical patients as a result of having high dependency availability. In 2012, we got a grant from Scottish Government, and we were able to implement Phase 2. At that stage, we had developed a course in Scotland for all members of staff working on the labour ward, and it was emergency skills, team training, and we got a grant to take that into the labour ward in 3 districts with the highest maternal mortality, and included the guards and drivers. This is one of the faculties. You can see far more local faces on faculty. Just some slides of the local faculty teaching their colleagues, small groups, skill stations and scenarios, and the total number of staff trained in each of the centres over those 3 years. Guards and drivers also receive training because they are often the people who present the hurdles to women receiving the treatment that they require. And you can see there's been a massive impact on the maternal deaths. These are annual figures from before we started the project until the annual figures when at the end of the project. And this is just the slide of the New Blood delivering the course to the folk in Malawi, in Jamaica. So you can see there on the left the faculty and on the right, the delegates in the Jamaica course.
Thank you very much. So I'm a gynaecologist, and I'm going to speak about the very small part that I played in developing a cervical screening programme based in the Lacoux hospital in Malawi. This was spearheaded by Professor Cubey and Christine Campbell at the University of Edinburgh, and was a 3-year programme funded by the Scottish Government, but I just came in right at the end. Sadly, Africa has the highest incidence of cervical cancer in the world, and Malawi has the highest incidence in Africa. Catriona has said, if we go back to the millennium, 6 in every 100 women would have lost their lives in childbirth due to the amazing initiatives that Catriona has described. That's now down to 3 in every 100 women. But of the 97 women that survive, 7 of those women will lose their life to cervical cancer. So cervical cancer is a massive killer in Africa. Why is that? Cervical cancer, as everywhere in the world, is due to the HPV virus. Even if we could afford the vaccine, which at the moment is unaffordable, there would still be a huge burden of HPV-related disease in a cohort of women who have never been vaccinated. Customs mean that, unfortunately, very young women are exposed to the HPV virus. The incidence of HIV infection in Malawi is 10%, and women who are infected with the HIV virus cannot clear the HPV virus and are therefore at much increased risk of cervical cancer. And there is really no effective programme of screening or prevention. As with everything, a lot of it's down to money. The government health spending on healthcare in Malawi is $25 per person per year. Even if we could afford cervical cytology, Frank has illustrated the problems with staff to read the smears. I think currently there are 4 pathologists in Malawi for a population of 16 million, so that's a non-starter. But there are other things that are affordable and available. Acetic acid, which we use in our clinic here, is affordable and available, and we can use that to do the most basic of tests, which is applying acetic acid to the cervix and looking for aceto-white change. It's basically colposcopy without the colposcope. The reason Dundee's become involved is because we use the so-called cold coagulator. It should be called the thermocoagulator because it's heat treatment. This was pioneered by Ian Duncan in Dundee, and in Dundee is used in our clinics to this day. The advantage of this machine is that it's small, it's portable, you don't need any consumables, everything about it is reusable, and you can take it out to a village health clinic and treat on the spot. So we can train the local practitioners to identify a normal screen-negative cervix and a screen-positive cervix requiring treatment. So education is the most important thing, and long before any of us arrived, the local healthcare providers were working at what they called developing sensitisation sessions, where women arriving at the clinic would sit through sessions about not just cervical cancer prevention, but sexual health, HIV awareness, and family planning. And this was embraced incredibly enthusiastically. There was some resistance, I gather, to start with, but people like this woman are very important. She's one of the village chiefs in Malawi, and as soon as she came on board, there was great acceptance of the whole programme. So in the first phase of the programme, the clinicians from Edinburgh went out to train the local clinicians. So that's Hilary Walker from Edinburgh, training 2 of the first nurse practitioners. That was supported by a training manual and a really very rigorous system of CPD reflection and audit. So the questions posed in 2013 was, can we train the nurse practitioners or the clinical assistants to deliver this programme? Will the women engage in the programme and come for screening? And is the treatment effective and practical? So I came in really right at the end when we were assessing the programme and really found it had been very successful. Over the 3 years, 37 healthcare providers had completed their training and had been assessed by external assessors, including myself. Women were incredibly keen to engage in the programme. Of a population of 400,000, 100,000 women have attended the education sessions. Of those 100,000 women, 17,000 women have attended for VIA screening. Of those, 6% of them are VIA positive. Almost all of them have been treated, many on the same day, because the geography of coming back for treatment on a different day is very challenging. Follow-up rates aren't ideal, but again, considering the geography, 50% I think is quite good, of whom 90% are screened negative at their follow-up visit. And we can deliver this in remote areas, so we had a hub and spoke model with 10 peripheral clinics, and 10 of the 17,000 examinations were done in the village health clinics. This was all brought together at a symposium during our visit, which amazingly was opened by the First Lady of Malawi and attended by most of the VIA practitioners, certainly in that region of Malawi and from across the country as well. And I just want to really thank the whole team. As anybody who's worked in this sort of situation or any situation knows, you can't do any of this without a team. Fantastic team of local nurses. That's David, the medical director at the hospital, who some of you will recognise, who worked with dedication, commitment and professionalism. And as you know, if your team has that attributes, you can achieve a lot even with very limited resources. Thank you.
In contrast, I'll mention a massive organisation, Médecins Sans Frontières. I've been involved since 1999. I've been away quite a few times with them. Is this the right button? Yep, looks like it. I won't talk about the Antarctic. I'll just talk about these countries briefly. Okay. And MSF, I think it's an amazing organisation, but of course I don't have to do the organising. Other people do it all for me. I just arrive and do some work and then go away again. I think the bottom one really is to get a massive background that they can draw on at any stage, and so if there's a cholera somewhere, they can press a button and do it. Obviously they're the Ebola people, so many things. HIV's been a fascinating story for them, multi-drug resistant TB. But I'm just going to touch on some countries, mention what I was involved with, but also mention what else MSF were doing there. So this is Lebanon. This is my first trip, so maybe 1999. And the bottom half of Lebanon was occupied by Israel. I was in a Christian enclave. MSF were working both in the Christian bit and the surrounding bit, Hezbollah-controlled bit. So the first time I've been exposed to tracer fire and all the windows covered in tape, and so that if there's a blast, you don't get covered by glass and whatever. I had to do a bit of anaesthesia, a few little things. I didn't have to do very much. I sorted out the cupboards in the hospital. A beautiful place, very interesting, and although it sounds dangerous, it wasn't dangerous for me. Jumping to Sierra Leone, probably where I've spent most time. I think I've been there 6 or 7 times. They had a very complicated civil war, and MSF have been involved in all wars generally and involved in the wars that are going on now. They don't advertise it very much. Sometimes they're in the country, sometimes they're in the countries around the country that's having the war. Sierra Leone was incredibly complicated. Just to illustrate it, one of their expressions there was Sobel, meaning I'm a soldier by day and a rebel by night. And so there was just enormous banditry, all sorts of terror and stuff. This gentleman, it's his left hand, in fact this is the painful one. I work in the pain clinic. We did a pain related thing there, but a dignified leader of a big family. He's just had been lined up in a line and had his hand chopped off. Similarly, rape, this girl with a leg chopped off. Then obviously rape in wars now is a very, very common thing. This was the theatre there. We had a theatre fire there. We had lots of animals in there, all those usual things. Elephantiasis is just, was an unusual thing to come across. Then more recently, going back there, the Ebola thing, I was there right at the end of it. I didn't have to do anything hardly. This is teaching about, what do we do if in our little place we get a case, and just reminding everybody the palpable fear around, because they all know people who've died already. Lassa is another viral hemorrhagic fever, and that was very common. Not common, but I mean it's a good frequent in Sierra Leone. And so when Ebola broke out initially, then they thought it was Lassa, and so the experts of Lassa for the world were wiped out in the early days of Ebola. And all of these people knew other healthcare workers who died or had been thrown out of their houses or whatever. Very impressive what other people will do for other people. Sri Lanka, then this double doors at the back, that's where the people who had tried to commit suicide, usually women with some sort of burning stuff, were put and not nursed and allowed to smell and rot and die. Things improved enormously with my job was I wasn't there then, this is later on I was there really on the pain side of it, and burns around the world are just a fascinating but also a sad, very, very, very resource soaking up thing. So this gentleman, if I can go backwards and forwards, then so the same gentleman, just reminding us how we hypercatabolic. We were doing some palliative things there as well. Abkhazia is a breakaway part of Georgia, so it's just below where the Winter Olympics were in Russia. There's something. Chechnya, Sochi, thank you. Chechnya is there, and so area of lots of conflict. So this Abkhazia, then they broke away from Georgia, and there was a civil war there. And I love the fact that this organisation will choose to go to a country that nobody recognises, will negotiate with people around to be able to get in, will do something completely ridiculous like treat multi-drug resistant TB there in a prison. You think, wow. I was involved with, I think, mostly pain things there, a little bit of anaesthesia. And Haiti, then, this is before the earthquake. But MSF were already there when the earthquake happened, so that was very useful from that point of view. But they had a big trauma centre already. There's another part of MSF doing an obstetric thing, 11,000 births a year in their obstetric setup. I was involved a bit with anaesthesia, a bit with pain things. And again, I love the fact that so this is somebody at home. She's been shot in the back. She's paraplegic. She's supported by various people. MSF part of that, but she lives up there on the hill there with all those concrete buildings. That's what's all then swept down during the earthquake and squished everybody. And of course, as you know, after the earthquake, the massive thing that happened then was a big cholera outbreak. They didn't have cholera there. Unfortunately, the UN took it there with their soldiers. But that was a separate issue. Thank you very much.
Was it going the wrong way? Okay, last but not least, folks, I'm going to talk a little bit about our emergency medicine project in Malawi. Malawi's featured quite heavily this lunchtime, and Scotland and Malawi have a really unique historical relationship that the Scottish government forged with the Malawian government into a Scotland-Malawi link that really has endured over the last decade or so and continues to flourish. As you've already heard, I was involved in the Scotland-Malawi anaesthesia project with Catriona Connelly, and this is Queen Elizabeth Central Hospital in Blantyre in Malawi, the only teaching hospital in that country. And this is a very historical picture because that's the administration building of QECH, which has now become the first dedicated adult emergency and trauma centre in Malawi. Because I was out with Catriona, and because I'm a Dundee graduate and did my elective in 1987 in Malawi, I still knew some folk there, and they twisted my arm up my back and said, we need an adult emergency department. We've got a great paediatric one that's halved the death rate of children on admission. We think we should do the same for adults, but we have no expertise. Come and help us. And I was there, and I thought, well, with the Scotland-Malawi partnership, we could do something. So at the behest of the Queen Elizabeth Central Hospital, the College of Medicine, the local steering group, they had building support. The Malawi-Liverpool Wellcome Trust from the Liverpool School of Tropical Medicine's on site. A big banking family made a big donation to help refurbish that admin building. So lots of things lined up really nicely for this. And we were approached to be the Scottish team with emergency medicine expertise to help them. You can't do this alone. And you know, my strategic team is multidisciplinary. It's as much about as teaching clinical skills as teaching non-clinical skills, and empowering the emergency nurse workforce in Malawi, who were gentle and passive and shy, which is not like emergency nurses I've ever met anywhere. But I'm indebted to my lead nurse, Gwen Gordon, see her cuddling one of the children, Russell Duncan, one of my consultant colleagues, and Linda Imrie, one of our charge nurses, who formed our strategy team. Oops, I'm going backwards, wrong. No. And of course, it's a person-to-person link, and these are really important. Catriona mentioned that with Cyril. Godaya, the anaesthetic link, who's absolutely key. And for us, it was key to have a physician, and Melinda Narendra was the key physician with our project, and a key matron. And this matron took no prisoners. She was absolutely formidable in her meetings with particularly expatriate staff from Europe, because she floored them all. She was great. This was the A&E department. I mean, that wasn't even like Dundee Royal Infirmary before we moved to Ninewells. I mean, it was a bike shed in the worst state school in the land. 10 times the volume of emergency patients came into that, sometimes 20 times the volume that we have for a busy day. So a busy day for us is 150, 160 patients. They used to see 3,000 patients on bad days. They stopped counting, and they certainly stopped caring. There was no prioritisation, no treatments, and people died in that waiting room. So our objectives were very simple: to reduce the mortality, to enhance the standard of care delivered in the emergency area, to introduce a fit-for-purpose training programme for the staff, and a train the trainers so that it would be self-sustainable, to encourage some collaborative emergency research, and to leave them with a sustainable, coordinated, multi-specialty emergency facility that's recognisable by anybody in emergency care. This department, our department in Ninewells and Perth, did a lot of extra fundraising. We kitted them with scrubs to give them a new identity. We took over. Scottish Government aren't keen on you supplying equipment, because equipment goes, but we had to train them on triage, and they needed to measure pulses and blood pressures and temperatures and things, so we had to give them kit, and we just left it with them, and it's used to this day. And we also trained, the little picture on the bottom shows the train the trainers groups. So this building, thanks to multiple investments, was converted into an emergency facility, which opened in the latter part of December 2011. And you can see the sort of difference for the patients waiting. But what was the most important part was actually, for the first time, those with the greatest need for care were treated first. And you can see the sort of environment was very open plan, but that was good, because that means we could keep an eye on everything that was going on. And for the first time, that department had prioritisation to a resus area, and they were delivering earlier treatments with good success. We went against a life support type course programme because we couldn't get them off the shop floor, so we had to go on the shop floor and teach them. So we like Hector in the Iliad, we followed a true mentoring service, and we joined our Malawian colleagues side by side, not just delivering improved clinical skills, but non-clinical just as importantly. And there were opportunities to train and teach, but the vast amount of material that comes through that department, real pathology that the likes of which you would never see working on the banks of the Tay, meant that we had an ample opportunity of real-life teaching on the shop floor. And the guy just about to bag and mass that patient, they wouldn't have ever dreamt of doing that in the emergency department before, is one of the new trainees in emergency medicine in South Africa. In a year's time, he'll be a consultant in emergency medicine in that country. We also set up a CPD program and a training program that actually still goes on in this classroom that we set up and equipped for them. And they were very interested in learning about CPR. I felt that if they were in cardiac arrest, that was the least thing they needed to learn about. But they were all keen to learn that because that's what we do over here. So we did do a bit of sessions on that as well. What was the impact of this? Well, earlier initiation of treatments, less emergency admissions into the hospital floor because we had an emergency department observation ward, so some things were treated within the confines of the emergency department and sent home from there. And there were anecdotal reports from the clinicians that there were less deaths on the wards because of it. The Scottish Government have been enormously supportive. Hamza Yousaf, who was then the then Minister for International Development, visited in 2016 with us and saw the ongoing developments that were on, and at that stage pledged to match funding anything else we needed. You've seen this map already from Neil. While Blantyre is often the focus because it's the only teaching hospital and teaching centre, there are other major central hospitals that are of the same size as Blantyre that need an emergency facility. And Camuso at the top is the central hospital in the capital in the long way. So this February, the lead nurse and I visited Camuso. We met with the hospital director and the head of medicine at their behest and the Ministry of Health, and we're actively seeking funding, hopefully with collaboration from the Scottish Government, to roll out the adult emergency service elsewhere in Malawi. Thank you. As I'm the last speaker and we have just about 6 minutes left of the session, can we urge everyone who's attended, it's already been indicated from Martin that you've all had an email, you should have had an email through to fill out that survey about global health and the need for it. Everyone's views are important and valued. If you would listen to that, if you would fill that in, that would be really helpful. If you want more reading, the Global Citizenship report from the Royal College of Surgeons and Physicians of Glasgow is an excellent read, and if I have time I will just I think I've just switched her off. I will play the CMO's 2-minute or 3-minute address about global health. But thanks for everyone for coming and listening to what we've had to say about Tayside's global health.
Many NHS Scotland staff give their time and expertise to volunteering work in healthcare settings across the world. Many of you will have been involved yourselves, or will know someone else who has. It's common for Scottish staff to experience significant personal and professional growth from time abroad. When a health service worker steps outside their normal environment, it frequently leads to better cultural sensitivity and an openness to doing things differently. I believe there's much to learn from healthcare colleagues working in different and lesser resourced environments. They often show great ingenuity in these situations and a healthy pragmatism in service delivery that we can learn from in the NHS in Scotland. In August 2016, the Royal College of Physicians and Surgeons of Glasgow was asked to undertake a review of international volunteering activity by NHS Scotland staff, to provide an academic analysis of related benefits and risks, and to suggest how global health engagement from the Scottish Health Service might be improved. In addition to published research, this review has taken account of views gathered directly from all of Scotland's health boards, as well as charities, professional organisations, subject experts, and the volunteers themselves. The report makes clear many benefits that these individuals and our NHS system can accrue from exposure to health problems and healthcare delivery in less developed economies. Successful development work in partner countries occurs on both long and short-term visits by Scottish staff, but sustainable and meaningful change is made more likely where the principles of effective partnership are carefully followed, including, for example, alignment with existing priorities in that country. The report does not shy away from the challenges inherent in international activity. Particularly noticeable is the challenge of maintaining the high quality of service to Scottish patients while our staff are obtaining experience abroad. Health service concerns about service gaps may explain the experience of some volunteers who unfortunately report a lack of support for their international work. I'm happy to welcome the recommendations that the College makes for improving our engagement with global health needs. Scottish Government has a clear commitment to global citizenship and to the attainment of the UN's Sustainable Development Goals, both domestically and internationally. This report outlines how the Health Service can play its part in that commitment, with the articulation of a distinctive Scottish approach to global health engagement. This will make responsible use of our intellectual and human resources, and this will welcome mutual development and capacity building which can occur.
I'm going to have the 3 minutes CMI. Primary care. What's sorry? Has it not? Oh, we should get it. Yeah, because there's some. Primary care. Do you not have anything? Do you not have that service? I was just thinking, I can't think that. And actually what's coming out of the group, so that that's disseminated to people. I've never seen speed dating on Grand Rounds before, but it seemed to work, didn't it?
Well, yours is on the thing, it just didn't have the PDF. Your slides are on. But anyway. Yeah, I think so. It was hard to focus whenever, you're waiting to speak in your mind, and then I left my timer with somebody else, but I realised people were just keeping to it, so it's worked very well. That's great. Yeah.
It makes some sort of circuit, doesn't it?
Communication between one end of the table.
I mean, one of the
So I'm hoping we got to start today.
Well, I think just the GPs, it looks like the primary care.
I think that
I'll check, for people senders from yesterday, because I think it was an issue of GPs. So I'll let you know. So do you want us to send some dates from the ASCO for trying to get together? The deadline for the surveys and then in June. Maybe just sometime after that.
Yeah, that would be great. Are you going to collect the results of the survey, or what were you thinking about?
I can do that.
That would be great.
I think we do.
Oh, good. That's terrific.
That's the theory. Once we get a chance to get to that,
so it'd be interesting to see what people feel about having this
So we'll medical education and we'll try and put dates out for next week. But it's trying to get
that's great. That's great. Thank you. It's really good. Thanks a lot.
Neil showed of two people on times. So when we took out 30 times, he knew he did. The charity shops and of times. And we got teaching each other times, because what they do is they say, right, this is like to teach a time. And then you say, talk about doing time. When you start to read it, you need to sit next to somebody. You need to say, how do you currently tie a tie? You say, here's a tie for you. That's my ties. Nobody took a spare to me. So it's learn a learn. And then we got sitting back to back. It went to the diagram. It's a Friday and Saturday. It doesn't matter. Sure, but if I'm teaching, if I'm getting into we sit back to back, they can't ask me anything. And then, of course, when they share the diagram, there's no, there's nothing. And then you do it again. You're just back to back. And you can ask, I ask them, this much. So I say, and how big is this? Does it get back to it? And they talk about the bottom, and suddenly just by changing, they love it. And 2 day course, it's in Blantyre, it's in Conway. But what was lovely was, it was 230 something that were the science teachers, and clinical teachers. And back there's a guy who days together, you don't speak to each other. So because we were a series of early lifetime Christian inquiry questions, they all come in their first thing terms, lots of interactivity, and it's done a lot to change the faculty culture. And it's great, so I'm going to put together just a grid that says there's just some just
individual world. So yeah, that would be great.
So we might be in touch and say, just fill in this grid, very simply, something like that.
Yeah, that's fascinating. Education, because I grew up with in a way,
what was nice when we were there, some people had just come back from Cape Town.
There are lots of things.
Saying how much they appreciate Malawi's doctors. But of course, what you've got is this leakage of Malawian doctors straight into Cape Town and beyond.
Thanks very much. I think that couldn't have gone better, really, in terms of timing and everybody being slick and getting the message across. That's great.
Thanks for coordinating. Thank you.
I'm going to make use of today. I'm going to get in touch with them just with a simple grid that says what you did, what were the main headlines, because I'm probably going to be tasked with writing this first page to this global challenge research. Well, basically, this global challenge research fund has a pot of £1.6 billion.
Scottish or UK?
It's UK.
This is the NHS England thing, isn't it?
No, this is all of the major funders in the past, like Newton, ODA, OECD, all of those all coming together under this thing called the Global Challenge Research. And so there are 6 groups at the moment in the university who have got in that bottom tier to start now. And all we've got at the moment is some pump private to go back to Malawi again to establish partnerships and formalise the partnership. But then we know that when the bids come out, there's going to be fast turnaround because they have to start getting this money out. So there's likely to be a bid, a call in July or August. And so what I need to do is to capture the sort of historic links with Africa. I mean, we're going to start there just because there's been so much work, so we can demonstrate there's themes coming through, like not of sustainability, all those messages.
Yeah, I was saying to Catriona, I mean, one of the common themes in all this is challenges in measuring the outcomes of the impact of that education. And we're all doing it, we're all trying to do it, we're all doing it in different ways, and unless you set up cluster randomized controlled trial, you can't do it, but you can't do it in a really scientific way, but there must be ways. There must be ways of doing it pragmatically.
But it just strikes me within the solution
I teach qualitative research methodologies. And I think the sorts of things good, let's do that. But I think the thing is that with this global challenge, they're seeing funding for PhD students, for example. So we've already got somebody there who wants to come do a PhD with us, looking at distance learning. So, basically, we can one or 2 PhD students a year or more, perhaps. And I'm thinking that the start point could easily be about evaluating what has worked. So using appreciative inquiry to say, rather than what do they need, you say, what's worked, what did they think has worked? How do we measure the hard to measure stuff?
I've got a trainee who's a Squares lecturer, and she's got a really international house.
It's taken for life, it's just taken for life. That's just life.
Short course education in a local country. So again,
well, we're looking for people to be on our stage.
She's going off to one of these systematic education courses. Because, we've got our master's with my dissertation, research dissertation, including systematic review. So, but it sounds like she's already got a PhD. She postgrad. So the idea is that she develops research projects and then applies for a PhD. So she might be really interested in that.
Why don't you ask her to get in touch with me? That sounds like a couple of cups of coffee and a rich conversation.
Just scared of Catriona. That's what your colleague said. They said I was amazed that everybody spoke so well and said it's hard and you don't just comment so much.
I'll send you an email soon.
Fair enough.
She wants to do systematic
I didn't even look at you for my time.
So it's an accepted but oh yeah, okay.
We're going to try and get some data.
Long chat to him, but he was just talking a language that was clearly doing that sort of research in medical education is totally
it does include, I mean, your inclusion criteria.
Yeah, no, but they were
studies and it would include qualitative stuff, so you wouldn't just be looking at the kind of high impact.
So I like to try and get a systematic view of the time, but also
Well, we might like a reason to the supervision
feedback. So we've got
but you see, we've got.
Well, the other person is really good at Christian my side. So two things I didn't talk about was the virology side of it. So Heather Cuby was there as a virologist for the impact of HPV testing, but because that wasn't my baby, and there was no time to talk about that. Christian as the health science. Which I'm just a tiny bit. Thanks very much. Thank you. So yeah, so we're just having this Christian. Probably.
So, I think we should just follow up.
See, the first thing I would say is see that word Kirkpatrick and evaluation.
And it was the week before
Already, so actually, when I saw someone walking in, I thought, there'll be plenty of opportunities. There's lots more things going on.
Medical education.
And it's all on YouTube.
If you're doing randomised drug control.
Oh, sorry.
Very gracious. Forgive me.
Use quality. That's recognised.
Sorry, I should have thought of that.
To be fair,
you had produced a program.
Time 0, 12 months down the line. Really.
So these guys are talking about
what could really make it rich is to supplement that versus quality.
so what do you think we should do? Should we try and have a meeting or something? Well, maybe it would send someone
develop skills in that area.
The survey's due on the 9th of June. They're going to get that.
Well, we're looking at
very quickly and really look at the response from
so build a capacity for that ongoing.
We probably have
develop the capacity with upskill people to measure these
No, that's great.
And then we start to get more PhDs and we start to become more leaders in global research.
Absolutely.
And I think we'd all
So I think if you were to try and link all this stuff together, that's one thing that runs through it all the time. That's one of the things
I think what they would expect is for us to develop some online teaching distance learning type things that could be accessed by the likes of Dubai and various places like that. Bring the money in and then any access that's made, we would get 5% of that. It's like you might end up with 20 pence or something. So
I've seen the document that came out later. It's very much activities. So
because
it's not really the ethos that any of us going to.
I've had some very difficult discussions with them.
Well, and also, I have done some online teaching, but I've done it through the International Colposcopy Organisation. So you wouldn't label that as NHST side, you would label that available to the wider colposcopy community. And also, I didn't charge it. You just do it for free. So, I didn't know. They didn't offer to pay me. I didn't like to ask them. But
what we face all the time
you probably wouldn't expect that.
well, it's just like you don't get paid to do this. It's part of your job.
No, I'm not.
On that side, they do charge
that's
quite a
what
lot.
we need to be saying.
Can we develop it? That's I think that's probably the answer.
But then they use the money. I think they use the money for subsidising
maybe what we'll do is
because the course, even the online course was unbelievably expensive. And I said to Walter, you can't possibly expect me to do this. It was more than a year's school fees. I looked it up. A year's school fees. One of the average private schools is like £400 a year, and this course is £400. You can't pay a year's school fees. But I made that point to him, and I said, look, you've got to make it affordable to the really low income people. It's fine, sort of. But the IFCPC is obviously for everybody, and developed countries, but it's used a lot in Eastern Europe and, as you say, Middle East, so you can charge. I'm not really
I think now that we've got
it sounds like a really good
GPs,
so I'll get in touch and I'll get in touch.
CME?
and any other
Well, I was going to mention, because we've had our group together, Global Health, and I'm trying to get another meeting with that together. I don't know if that would be an opportunity.
Yeah, I think so.
Just to try and do that.
Yeah, that would be brilliant.
To try and do
yeah,
that.
I think that would be brilliant.
Because we've got university people as well.
Yeah.
I mean, since we've established, it sort of comes and goes a bit, and depends who comes. But we could try, I could get everyone who is here today, just include all the email addresses, and everyone, just try and pull together. Because the other thing that the university has sort of agreed is to sort of try and look towards setting up a sort of overseas site, an overseas partner, which I presume could be like more of a country, it could be. It hasn't got to just be one centre, but it could be a company. We have got to focus on Malawi, but it could be. But they've agreed. All the deans of all the schools have agreed to sort of work together to sort of help develop. Obviously, they wouldn't come with any money, but it would be done very slightly. But it would be allowed sort of multidisciplinary sort of collaboration.
And access to the expertise within the university.
But it would include NHS, because through our sort of NHS university.
No, that would be good.
So we're going to try and... So we had a brief meeting initially to talk this called Dundee University International Partnership site, and we had a meeting to sound people out there. But we could have... with
thank you.
A sort of joint meeting and just try and brainstorm how we might actually take things
forward. Thank you. Yes, well, it's not me. I mean, it's
yes, no, I'm happy to do that. I don't want to sort of... Yes, should we just do it ourselves? Maybe not. Because we're sort of NHS university, we're sort of midway up. We can include...
And the NHST is more of
Well, they do seem a bit like that, don't they? I mean, I thought if they could help in, for example, facilitating people to get away, do that, but they don't, or they don't seem to be...
Well, I think they're keen to... I think they say they can, and they bring business cases, and they can do all that sort of stuff, so we can have that expertise. But I think if we were to start off, with a meeting with all the people who are actually doing work, and then brainstorm, and then clarify what our expectations of the HSP involved would be, that would probably be a good idea.
So I was speaking to them about this the other day.
And there is this thing of setting up, as I said, into one sort of focal point for the university is through a partnership. How we form that, but it could be a form of,
lots of organisations and institutions across the
but having sort of one particular focus.
In
which case that could be involving students, clinicians, and things. So but we can brainstorm how that actually works. But there's support from the university for doing that.
Well, that's brilliant. Shall I just, or do you want to just email the group and just?
What I'll do is I've got it's actually Susan Wilson down in Mackenzie Building, and actually Abby up in this. We've got the sort of a couple of distribution lists. They're already trying to put together, going to send a doodle poll around to try and set things up. So should we do that? Is that all right? Whether you've been coordinating that, I don't want to sort of stand.
I was only doing that for this.
No. I didn't want sort of things. I'm very happy. No. I don't want to. Because I think it's probably a joint. I think it's always good having multiple people.
I was off sick for a wee while.
Are you okay now?
I am thanks, but I wasn't sure if I was going to do any just when I came back, and that's why I've just distanced myself from a lot of it. And I am kind of much better, but also I'm happy to do it from a more strategic thing, and I'm on her group now, representing our college, and so I'm very keen to kind of be involved from that thing, and we have got a lot of experience from what we've done, but I'm not so keen to be going out. But I think there's enough
need a sort of steering. What I think probably needs to is sort of a steering group who knows, because there should be experience. We try and set things up, and then we don't actually, then we lose, you lose track of what's going on. So have maybe a steering group that actually can take things forward.
That's why we know that we have that in publicised it.
Yes.
People then who've got ideas come to that.
Yes.
Just get inspiration.
Yes.
So if that becomes the kind of...
Right, so we
thank you so much.
But the more people I speak to, something like, oh, we have to, let's try. It's a kind of big complex jigsaw trying to fit it all together. But this time, make sure all the people
and I think we've got various
common strands.
Yes,
So if we focus on those common things, about
has been funded to do a PG,
access,
but she's actually now got qualified to do a master's, which means that the third part of it will be research. And I'll be supervising that. So you've already got somebody who can do qualitative research, and then hopefully waves of that, more people coming. So you build up that capacity there, so they become the centre of excellence. We simply go in and support it and feed it and work with them. So this has been great.
So from the screening point of view, I'm sort of under two umbrellas. So obviously the work I did was through the University of Edinburgh, and the Scottish Colposcopy societies are fairly sort of united group. We meet once a year, and I've spoken to them. So it's sort of got a Scottish perspective as well as an Edinburgh. But then there's the British Colposcopy Society and the International Colposcopy Society, so I'm sort of working under both of those umbrellas. So some of the training that I've done since, I've produced online modules for the International Colposcopy Society. But the problem is there it's colposcopy, and we keep saying colposcopes are bigger and expensive. You just need a pair of specs and a bit of vinegar. You've got to keep it cheap and affordable. And you've got people in colposcopy saying, "Oh no, you've got to be able to do colposcopy. You've got to be able to do loop excisions. You've got to be able to take pelvic filters. You've got to be able to do cone biopsies." And it's like,
But
you know what Frank said with the pathology. I mean, we were getting, because we did have a separate arrangement through charitable funding in the US that if women needed surgery for cervical cancer, that got paid through a separate fund, and we got pathology reports on that. But we couldn't do any biopsies in your here you do a biopsy before you treat something. There you look and you blast, and you hope you're doing the right thing. So it is, and therefore you've got to have how do you get the measurability and how it works. And that's
so
what
basically, this is looking at what's nice about this fund is it's got a 15-year to being self-sustaining. But that's realistic, it's got that, and especially given 10 years. So we can say we've got a 10-year running, we've got some evidence, we can start to use PhD students to look at the evidence so we can move forward using an evidence base, a different sort of evidence base, an educational evidence base, and what's worked and why has it worked and how can we replicate what's working that's emerging from there. But it's like my thinking, and I think what they want, my understanding, I've been to 2 days now of sort of briefing on how to win this money, is that they're seeing sort of bigger pictures. They're wanting to see interdisciplinary. Okay, so for example, one of the things, Neil and I were walking along, and Emma said that if she had a wish list, one of the things would be the money for an incinerator. No incineration, in a country with 10% HIV, and higher percentage arriving in the hospital, and yet people with bare feet are trying to burn this stuff, and only a tenth of it will burn. And I was thinking, we could bring in, the design team, the engineering team. Let's find some solutions which are cost effective, not which involve sort of paying. Because the other thing is they're not interested in funding anything which gives us more work. So obviously we need people to manage and run big bids ultimately. But I just think we could certainly be working with colleagues in Duncan George and Stone, looking at design, creative designs. We could be looking at with engineering around what's the safest possible method that could be used and could employ local people safely. And then let's research that, and then you're in the zone for this sort of money, and it's going to keep coming in. So we've got to get in at the bottom.
So do you know Christian Campbell in Edinburgh? She's a health scientist, and she was one of the two. So I was involved with her as a health scientist and Heather Keeley as biology. Because the other issue is you need to introduce HPV testing into the programme, because that's not. Christine Campbell. Yeah. So I'm meeting them again in a couple of weeks' time, because they've been to Malawi a million times. So the problem is that our money has now run out. That was the 3-year grant, but we're very keen to support an ongoing programme.
Well, my thinking is that, because you have to think about, so what can we ask for quickly? And I think that this, what you're talking about, which is you've got all this data about what works in various places, you've got some stuff. So if we were to start to say we need some PhD students who can capture what's working and why it's working, we need to be saying we want to follow up the people that have received the training. We want to. So it's a research money, but basically you're doing a capacity building. So we'd be looking at developing people who can do that research and evaluate and work and run it themselves, and then be saying, hey, but this is what we need. We need some more of that. We need some more of that. So it's not going in to just run workshops, but for example, I'm thinking we could put in something that said 6 master classes a year, but based on what they want, and then it might be on paediatric anaesthetics, a follow-up, or it might be on teaching sexual health workers. It could be, do you know what I mean? And I think it's only these sorts of conversations that's going to get us to a point where we can bring it together. But this money isn't to do it. You have to dress it up in terms of to find out the research. So so if anybody's got any thoughts about it, please get in touch.
I will. I definitely will. I will. I'm also to Good.
Thank you. Thank you for all your organisation.
Yeah.
I said we're going to need a meeting.
Okay.
To invite everyone to have a sort of general sort of talk about activities. Thank you very much.
Okay, thanks a lot.
Thank you.
Later. Are you waiting to come in here?
Good to meet you. So get in touch now. Yeah, thank you.
Yeah, so there's a cable there to connect to a laptop. Oh, there's mics here. There's probably a button that you need to push to get the mics on or something. Hello. Hello. Hello.
Those ones are on.
Hello. Oh, hello. Hello.
Hello.
Oh, yours is on.
Didn't you press that one? Little red button.
Hello.
Because then the orange bit comes on. That's it.
Hello.
Doot, 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 doot. The battery's not great.
Hello. Hello.
Hi.
Haha. It's
There you
working
go.
now. It's
Okay,
working now.
good.
3, 2, 1, 3, 2, 1. Right, okay, so that's fine.
Just want to make sure I put it off.
So that's fine. Yeah, you've got to hold it into.
Oh, okay, yeah, fair enough.